So welcome to Healthily Conversations. This is our podcast series where we're talking to health and social care people with an obvious focus around communication skills. And today I'm really pleased to be joined by Jason Corner, one of our lecturers in nursing studies over in our health school. The detail, it's the facts I'm struggling with.
Yeah, thanks for inviting me. It's nice to be here, and it's nice you made me feel at ease straight away because we've got a shared interest in running, which is always... This could get really boring really quick, couldn't it? Yeah,
we're getting to training plans later. So what would be really nice, Jason, just to hear a little bit about your background, how you got into nursing in the first place to start with.
Yeah, it's sort of quite reflective for me, the process that sort of brought me to this moment. So my friends... When I was younger, I was not academic. I don't think anyone's born academic, but I think sometimes there can be a perception that, academia is something that is just within you. And I guess that took me in a certain direction with my career. And before nursing, I was a personal trainer. I taught Pilates. I had my own business. And I was really into health. And I remember feeling really embarrassed when a colleague of mine says, "What do you read to inform your practice?" And I didn't really have an answer for that. I didn't really read. I don't think I read a book start to finish until I was sort of in my 20s, and even then it was a bit arduous. And something sparked in me at that point. There was a turning point in my life where I started to engage with literature, I guess, to inform the work that I was doing. And from that stemmed a bit of a frustration with an absence of my academic underpinning. And there were all sorts of bumps in the road until nursing. And I have to say that at that time I had a young child, and it wouldn't have been possible for me, and this is very pertinent today, unless there had been some form of sort of bursary or financial support. I have so much admiration for the students that are doing it now without that support. And equally, I just think I liked the idea of a profession, and I'd got bored of this career. I'd reached the sort of limits of what I felt I could do with that career, and I'd taken on a totally new role in care work with people who have learning disabilities, and I really disliked the first few months. I felt really uncomfortable. I didn't feel I was good at it, and I was about to give up, and then something clicked in me, and it's something I always come back to, and I can put a name to it now, which is it always comes back to knowing the person you're dealing with, and as soon as I focused in on that, I felt at ease with that line of profession, and then some people just supported me into realising that I could do nursing as a career, and that sort of, then I was on a tidal wave. I could keep going with that career path, but that might.
So I think there's many people who I think stumble on a career, and I think when you're younger, often people just think everyone knows what they want to do and where they're going to be, and for very few people that's the case, I think.
Yeah. Nursing's amazing like that, and any health profession is. That's one of the selling points of the career is, I don't know if it's personal to me, but I reach points where I think, I want a new challenge, and nursing is really, really flexible. And so is academia, and I like that. I like that feeling of sort of working with a piece of sort of a module or a patient or someone like that, and sort of getting to a point where I feel like that piece of work is complete, and then having something else that I can move on to, and that suits me. That sort of keeps me sort of engaged.
So there's quite a lot already to unpick there in that journey into nursing. So we obviously had an interest in health and fitness, is where it started. Mm-hmm. And then there was this, it feels like this seminal moment where someone asked you that question: How do you know what you're doing is right? How do you know this is the best thing you should be doing? And this, as you called it, this academic approach to, or maybe I need to read and learn a bit more about what I'm doing, was one of those key moments for you?
It was. There's a bit of ego in there. So at that point, I felt a bit humiliated. I felt a little bit, and this is a theme throughout my academic career, not that I feel humiliated, but this sort of balance between doing something that's useful and progresses knowledge and truth and all of those sorts of things, and battling with my desire to be recognised. That sort of that prestige element. I remember a really distinct thing in a presentation that I gave where someone says, "Oh, you're too self-deprecating, and you need to dress it up and sort of gloss over sort of the insecurities in your research." And I was like, "But I like that. I think that's authentic." And so I'm quite sensitive to that throughout my career, possibly overcompensating. But now my desire for sort of truth in sort of and informing my clinical practice, it's been a bit of a journey, but it's a really strong theme. That is really crucial to sort of everything I do.
So I think we definitely want to come back to this academic side, that exploration of truth and the appreciation of the journey and the fails and the challenges along the way that informs your practice and your career to date. Just going back to you walked into, transitioned into a social care environment and working with people with learning disabilities, I believe you said, and then the nursing career followed that path, or the formal training, I suppose, behind that.
Yeah, I knew nurses existed, obviously, but I didn't really know the pathway to it. It wasn't before the internet, but it was before you kind of did the kind of googly thing. And it was just working with the nursing staff. It was a forensic unit, inpatient unit for people with sort of learning disabilities. And I just remember having a conversation where I said, "I can't afford it. I've got a young daughter, etc., etc." And they said, "Do you know about this?" And I think it is important. Sometimes I'm a bit reticent of talking about that because I'm, where we are now with students paying their fees to do their tuition. But I think it's important to talk about a time when that did happen, because if we let it go and accept it as a kind of like, you have to pay your fees, then, I think it's an important thread to keep going, that once was the case and how that changed people's access to being a nurse.
So the route in for you was, one, important, that awareness that actually there was funding and support available to get into that educational background into a career.
Yeah.
And that came about through a chance conversation, almost, it sounds like.
Yeah, it's another theme in sort of everything I suppose it's hindsight. I really like, in my sort of practice today, I really believe in this kind of microsystem. I think it's really effectual. We'll probably get on later when we talk about COVID and et cetera, and my research in care homes. But this idea of sort of creating these microsystems between different people, and I wouldn't have known about nursing unless I had that, and I wouldn't have known about every postgraduate opportunity I've had without that microsystem, that kind of one-to-one relational stuff. And that's I think that's crucial to everything I do now.
So I think there's a really nice message there around keep talking to different people, because you never know where someone may have that idea, that opportunity, or the opportunity for you to then go down a different path in your career. So Jason, you had this time when there was opportunity to get funding and resources to help you into study. What would you say now to people thinking on their journey, their pathways, when maybe those opportunities aren't there? What would be your advice to students thinking about nursing now?
I suppose there's, in terms of the individual on the other end of the sort of application process, all I can do is advocate for nursing as a career, and that you will eventually be in something that you'll find incredibly rewarding, incredibly flexible, productive. You'll have a strong sense of purpose. So I can definitely say the output from doing nursing will be worthwhile. I'm not quite. I think possibly the other end of getting nurses into training in, mature students that possibly have families and can't support it. I think that's possibly our responsibility in terms of advocacy for that group of people, for us to actually have these sort of higher conversations and keep feeding back on a local level to sort of government, our guidance, our bodies, about how the lack of a bursary affects student access. We don't necessarily have a problem filling and sort of with admissions. That's not necessarily an issue, but it does change the sample, the people that eventually end up here, and there is a danger that we will miss a certain demographic of people without creating some form of bursary like we used to have.
And I think in the world at the moment, apprenticeships and particularly training in healthcare apprenticeships are really maybe that opportunity for that cohort of people who may not have been able to do it while we've had all these fees, that may open that door to learn while you're working, while you're studying, and get those qualifications. And I hope that will be a future route, so we get the full broad spectrum of society who can do all these healthcare careers that we need to do.
Yeah, absolutely.
So we've evolved in that journey for you getting into the nursing training and the formal training sphere of nursing, and you've gone down a route of specialising in a mental health area of nursing.
Yeah, so I always find it really odd. We sort of, I'm sort of going through a process of thinking this through, because we have this thing in, I don't know if it's nursing or in health, where we sort of, everything above the neck is sort of mental health and everything below the neck is physical. And I find it a bit bizarre, and I think there's a distinction between mental health nurses needing to learn a set of skills pertinent to people with mental disorders and trying to separate the body into those two things. I don't think that that's particularly helpful. And I think also it can be a bit divisive. It creates these imaginary boundaries that sometimes we need to be careful about with coaching different faculties of health into these kind of rigid boundaries between our professions. So I'm always mindful of that. That's come out in a module that I organised where I felt like it was a bit of a risk, but we went into mixed fields. So the fields in nursing are adult, child, learning disabilities and mental health. And I wanted to combine the groups, and it's been really fruitful. I wouldn't say it's better or worse. It's just been different in the outcomes from that approach. And I was really, really worried about that, because we do tend to feel comfortable in our silos.
I think that recognition in everything we do in healthcare and working with the patients we work with or the service users we work with is, no matter what their background, their complaints, their conditions, they are a whole person. And when you're caring for them, when you're nursing them, or when you're prescribing medicines for them, even if it's in one specialist area, you've got to have an appreciation of the whole to be an effective practitioner in that area. So it's really exciting to hear that in other professions the same thing is happening. We're recognising the historic silos that actually don't mean we have the best practitioners if they've only worked in one small niche silo for most of their career.
Yeah. And to answer your question, I've done a typical academic thing then of not actually answering your question. My specialism is generally mental health. I'm in the later end of the life course, so older people's mental health, and in particular I have a sort of specialism around differential diagnosis, so differentiating between what might be something organic, like a form of dementia. Not sure why we still use that word, but anyway, it's here. I think we've gone full circle with that one. And what might be acute confusion or some form of clinical depression. So differentiating between those two things.
So there's been a transition at some point in your career from the traditional nursing route of someone who may have been working in health or social care into this academic area of study. And I suppose I'm interested in, how did that transition occur for you?
So by accident. No. Okay. So some fortune. And that's why I think we have a responsibility to shout about insufficiencies in finance and healthcare, because there was a big, when I qualified, I was very certain in my last year that I wanted to work with people who had dementia. And that was something I definitely didn't want to do at the start of my training. I thought it wasn't an inspiring area of healthcare. I don't know where that came from, but anyway, at some point in my training it clicked. That's what I want to do. I feel like I'm really good at it. I get it. I enjoy it. And then I was fortuitous that there was some government funding that went into dementia care, and I originally got a postgraduate certificate, leadership in dementia, after that. And this is where the microsystem comes in, because none of this was me Googling, none of this was me sitting down for hours searching for I wouldn't even know what words to use to search for these things, that, they're all acronyms. And it was a corridor conversation at the end of the postgraduate certificate where someone else said, there's these fellowships, MScs in clinical research. I didn't know what a fellowship was, didn't know who the NIHR was. All I knew was that person talking to me was part of my sort of micro system, and I respected them. Investigated that, got a place on that. Really lucky that it was a fellowship that paid to backfill my my post in the NHS. And once I'd completed that, I remember joking to a friend. I said, "If you hear me talk about a PhD, like, can you tell me not to?" I said it slightly differently. And then a year went past, and somewhere through that year, my MSc supervisor emailed me and said, "We've got exactly the same thing for a fellowship, for a PhD." And at this point, it's kind of hilarious thinking of who I was when I was 17. It's hard to describe that person without giving too much away, but I was not academic. I was not really into effort of any kind. And I started a PhD, and I'm so glad I did. It's transformed, the MSc transformed the way I looked at, going back to that conversation about have you read a book. The MSc changed my relationship to my clinical practice in terms of how inquiring I was, how good I was at separating my beliefs from the real truth of the evidence. And I got into the PhD, and that was, as I'm sure lots of people listening to this and yourself are aware, that was a real journey. Yeah.
So I think several people, whether they go into healthcare positions in a direct route and knowing that's where their career lies, or whether they go into it along your journey path, which happens quite serendipitously, and opportunities, and you go down different pathways, research often doesn't come up very early. That's not where the thinking is at the start of that journey at all. And then for you, you'd mentioned this idea of the point of truth earlier on. You'd mentioned this idea of how do I know what I'm doing is correct? And that then reconnects a little bit more with, actually, this is where the research opportunity may come. Actually, I need to know more to inform my clinical practice. And again, the corridor conversations, which are so important and so valuable, have helped you access into some funding, some resources to then go and do this additional training. And as you say, start a journey, a PhD journey, which is a very much a journey in itself as you go through studies of PhD. So, Jane, just before we start talking about some of the research you've been engaged in recently, we had this career that started in nursing, and particularly around older patients and people who may have dementia. Mm-hmm. And obviously this is Consultations for Health, so I'd be amiss if I didn't talk about communication. So just going back to your early career in nursing and with that particular patient population, how did you find communication with the patients to start with?
Yeah, so I think this was the moment when I realised I was quite suited to this area of nursing. Was, I think, previously, before my first as a student, my first placement with people who had dementia, I'd been in a low secure environment, and that was my vision, because that's what I'd done as support work before nursing, that I would be good at, and I just wasn't comfortable in that area. And I think we're drawn to certain areas of healthcare for various reasons, probably related to ourselves. And I suppose there's practical things I could describe to anyone working with people who may have cognitive impairment, which is less is more. So being okay with the sort of slower pace, less information, can feel quite staccato. But what I soon realised, there was a really poignant moment in my sort of qualification period where I was a community nurse, where a lot of the things that people accessing health services because of cognitive decline would be concerned about would be diminished autonomy, diminished independence, diminished citizenship. Although at the time I didn't have that term, citizenship. And it's really fundamental in how I adapt my communication. And I just remember having a consultation with a gentleman in his house who was being assessed for a possible dementia. Very early on in my sort of assessment journey, I think it was within the first 6 months of that role. And at some point he just said, "Can I stop you?" And I was like, "Oh, crikey, what's going on here?" And he was very, very polite about it, but he said, "You've been talking to my wife an awful lot, and you haven't been attending to me. And I just had this realization of like, yeah, he's totally right. I have been doing that, and why I was doing that. And that totally changed my way of practicing, I guess. This theme of you're not going to take away my independence, I want autonomy over my life, is absolutely crucial in how I communicate to people who perceive that that's why I'm there. I would hear it time and time again. So my choice of words, my eye contact, if I see out the corner of my eye relatives kind of trying to get my attention, just subtly making them aware, always asking that person for permission to speak to someone else in the room. And also there's I wrote a book for my daughter, and it was a Christmas present to her. And it's this idea that we're very paternal of people in later life, which isn't well received. It wouldn't be well received by me now. You know, I like a bit of care, I like a bit of comfort and attachment, but not at the expense of disempowering me. So how I communicate with people in later life is really important. That infantilization, you've got to be really conscious of it, because it has an impact. You can see it's really tangible. You can see how it affects that person's perception of their abilities. And at the point of delivering perhaps a dementia diagnosis, that person saying, I'm not going to drive now, I'm not going to go to my bowls club, and slowly retracting themselves from the community because of, maybe my discourse and how I've constructed that assessment. And I think it comes from a good place as professionals. It comes from us having a desire to care and contain and keep everything okay, but it doesn't have a good outcome. When I do that, it disempowers that person, kind of disempowers me in a way, because I'm sort of, I'm not really giving them an opportunity to sort of gain control over their condition and sort of seek out things that will help them. So yeah, I'd say a sort of citizenship approach to communication, which is a slightly harder concept to get around, because we're used to talking about communication in terms of speak slowly. It's not really about that. It's about the content of what I talk.
So there's so many messages in there. So I'm just going to try and break those down. So I think there's the first training message, it sounds like you got, which was about when speaking to patients who may have cognitive decline, the message you are was about less is more and slowing down. And that sounds like that come from a training background that probably taught you those skills. Is that fair?
Yeah. So I mean, we could talk about it on a neurological level, but even in I'm sure most people listening to this will sort of sympathise with that. If someone gives me a sentence and there's about 3 or 4 components in that sentence, I struggle to interpret that and retain it and think, I glaze over and think, what are you asking me? Someone who's got some form of cognitive impairment, obviously, with a bit of background noise and all of those sorts of things going on, it's going to be hard for them to process. So that's kind of like a practical thing. And I'm doing it now, but we always want to fill that dead space. So there is a little bit of, how are you today?
Time to process and respond, and allowing that extra time that may not be the time needed for patients who don't have cognitive decline. In
people with severe dementia, there were some people that were in such a distressed, excitable state that even eye contact was too much stimulus. There would almost be a moment. I mean, it's knowing your person and your patient and where they are on their journey, but even that would be almost too much stimulation at that point in time, and you had to do this very sort of still being with someone to bring that level down before you start introducing sort of that relational stuff.
And then there was clearly this critical instant in your experience, this patient and their partner who you were communicating with, and the patient was able to say, hang on a second, you're not actually addressing me, you're not working with me, you're treating me as if I'm the second citizen in this process. And that really made you reflect on your practice and how you wanted to approach the rest of your career.
Yeah, it links into it, and this would be of interest to your listeners, ring theory of personhood. So the ring theory stems from palliative care, where people are very quickly viewed as innate objects. So their personhood isn't relational. Now we're relating, and people kind of observing us will see us as sort of broader humans in the context of what we're doing. However, when people are in a palliative state, very quickly the discourse around them becomes centered around them as an innate object, and that there's a parallel there to how we, and I say we broadly, it's human instinct, I suppose, to do that. But I need to keep correcting myself, that I don't get drawn into that sort of pattern of communicating with someone. Even when I've been with people who are in really, really late stage dementia, and there's, I know that if I ask a question, I'm maybe not going to get a response from that person, because maybe they're struggling to talk, communicate. And usually what I do then is I just try and sort of subtly, I'll tell them about my day, I'll tell them about a part of my life, so I'm still communicating with that person and not an innate object that I'm just attending to.
And so there's a number of themes I suppose people can take away from this. We've got, all of us have a whole range of unconscious biases, and that may be around that circle of life. We look after our children and we look after our older generations, and actually, but the older generations do need to be treated differently. They still want their autonomy, they want their independence, and that's a very challenging time when things are changing at that stage of life. And the communication must be focused on the person you're working with at all times, and being very conscious of, as you say, the words you use and how you're addressing them and the people around them, so they can feel that ownership and autonomy that they deserve in later life.
Yeah, 100%.
So some real interesting challenges through your career that evolved into one of research, and research in an environment which is particularly challenging, the environment of care homes with older people, and all the challenges that brings.
Yeah, and again, this sort of what I've just been talking about that compromise to citizenship, compromise to personhood, it's amplified in a care home. A lot of people aren't there out of choice; they're not out of there of their personal volition. A lot of these care home environments have very, very for safety reasons, rigid boundaries. And in my research, I saw the difference between care homes that had that sort of rigid boundary around the care home and care homes that had very permeable boundaries to the community. You see, even there, I was about to say the community outside, and it's very easy to say that, but it's not. That care home is part of that community. You're
creating a barrier by the wording you're using there.
Exactly. And I just think it all comes from safety. All of these things, even when I'm compromising someone's citizenship in the way that I'm talking, it comes from a good place. There's no one that goes intentionally into that situation to rob someone of that feeling of autonomy, independence and citizenship. I just think it's this sort of management of sort of positive risk, and I'll worry about litigation, I'll worry about accountability that sometimes fosters these practices. And that's hard because, you've got to have a lot of confidence to say, I'm doing this to promote someone's citizenship. I accept there are these possible outcomes. And you have to have really good knowledge of law and capacity and all of these intertwining acts of parliament, I guess. And
so we've got this environment we call a care home, which is effectively someone's home. But the difference here is, rather than choosing to go into that home, there's been a whole range of circumstance that has led someone to be residing within a care home. And then for safety, for governance, for a whole range of reasons, it's not a home like your eyes home where we can freely choose to come and go and move around and do what we choose. There's a whole range of barriers that are put in place because of good intentions that then mean that autonomy, that citizenship is lost for these residents living in the care home.
And that's where, during that sort of onset of lockdown, the first thing I sort of said when everything was being directed at NHS resources, that's all well and good, I just saw this big time bomb in the care homes, and it concerned me that this sort of well-intended paternalism would turn into something that was actually quite counterproductive in the maintenance of the people's well-being within those care environments. And that's where we get into dodgy territory. And that's where I get nervous. You can hear my nerves already. So the research that we did within care homes was really, really interesting. And it sort of highlighted what happens when that boundary around a really vulnerable environment becomes even more rigid.
So we've been talking a little bit about your research and the environment in care homes and this idea of citizenship and autonomy of the residents within the care home. Just moving back to the other elements of your role and thinking about the students you look after in your teaching, what sort of things do you do to engage them in citizenship and having their own autonomy?
Yeah, so it's sort of similar, and it goes back to what I was saying right at the start about this microsystem. Create yourself a microsystem. Those little fleeting interactions are so important. And I'm not in my private life very social, but in my work life I'm very social, and I don't know why, and I don't really think about it. But I enjoy that aspect of it. I'll cringe at this. So I'll say it. I've been nominated for the Nursing Times Educator, the University Educator of the Year. And part of that was the critical incident day that I planned with the entire third year nursing cohort, so and the MSc as well. So we're talking about 240 nurses all present in the building in one day, and the building turns into a hospital for the day. And the title of my presentation to the judges is going to be, "It was only one day, it wasn't worth it." And it's slightly antagonistic, but it takes it for a journey which basically illustrates how important these microsystems are in constructing growth in student learning. Another example is we did 1 million steps around the UEA Lake, which is about 2,000 steps. My friend said, I said, I bet we could do 1 million steps combined together. And he said, for that, you'd have to have, I think it was 10 people walking with you constantly over a 24-hour period. And I said, let's do it. And we did it. And it was just coming out the other side of lockdown. It created this massive microsystem of people that have been really, really in their rooms learning. So that's my thing that I seem to have fallen into this pattern of doing, and it radiates out, and it has this real impact on the cohesion of the learning environment. I think that's the key thing. Once you've got that, all the other stuff sort of sticks onto that web.
So firstly, congratulations on the nomination for the award. And what's
there's another one as well, but anyway,
the awards. What's wonderful listening to the conversation today. We started talking about these serendipitous interactions, these microcosms of community, and how you've recognised how important that is to the development of not only your students, but then in your research world. And I think it's a really important message that actually, if we can support interactions, if we can support people to talk, to share experiences, the learning can be huge, as opposed to isolated working on one's own, on what may go back to that description of academic studies and reading books. The world is much more than what's written on a page, and it's about the environment, it's about the interaction, it's about what's going on around everybody. And so the Critical Incident Day, 200
nominated
plus,
for an award as well. Teaching Innovation of the Year.
200 plus students faced with an event and having to manage the event. So I'm assuming there will be some evaluations from the students' experience coming out of that, or already been done. What about the staff's experience and the coordination and organisation of that? What would be your take-home messages from having done that now?
Yeah, so one question someone said is, how much did it cost in terms of resources? What are your inputs and what are your outputs? And it's a very reasonable question to ask, because it was 8 hours. It wasn't. It radiates out. So it's huge in terms of the resource. But the outputs, that they're not isolated to that one day. And I suppose as important it is to create this network for growth and learning in our students, I think it's really important to create that growth and network in our lecturers. You know, when I do that, everything that I teach, everything that I sort of report to students, that sort of communication is more enriched. So I think that's what I got from it. I can't necessarily speak for the other people, other than to say we're all knackered at the end of the day, but sort of knackered and smiling. And I felt this kind of cooperative of professionals, and it goes back to every opportunity that I've ever had. Really, that sort of microsystem of professionals.
So we will be looking forward to new events, new microcosms of opportunity to circulate with staff and students to build that learning journey.
Well, as a little plug, we're doing a parallel marathon with Street Child in Sierra Leone, and it's going to be around the UEA sports track. And we're putting in, if you want to put in a team, email j.corner@uea.ac.uk.
So there's a plug for everyone to get involved.
Yeah, so we're doing it at the same time because we can't fly out there.
So we've had a long journey ourselves today. Learned a lot about your background, your practice, and how that's informed your development, and that winding journey of what is life and a career that we all will go through or have gone through today. I suppose I'd like to finish with just saying, if you were looking back and at your earlier self, and you were thinking about someone thinking about a career, maybe in healthcare, maybe in nursing, what would be your one tip you'd advise to them?
Well, I don't know at that point what my advice would be. I guess at some point, if they were to pursue that career, any problem I've ever had with any patient, probably, and any relationship I've ever had, it always comes back to an understanding of that person's personhood. So whenever I reach that sort of block and I think I don't know what to do here, if I understand the recipient's personhood, where they're coming from, then I always get the answer from that. Yeah, it may not necessarily be that I've got a perfect answer, but I've got a more informed understanding of what's going on with our sort of interaction.
So if we can understand the other person or our patient through maybe view of the world, we're going to be in a much better place to support or work through whatever the challenges may be with them or with us, and how we solve problems together.
It always comes down to personhood. Yep.
So personhood is our take-home message from today. So I'd like to just thank you very much, Jason. It's been an absolute pleasure talking to you today, and thank you very much.